So welcome everyone, I'm Jean-Pierre from McGill. Bonjour à tous et bienvenue à la session Primo-Infection and Early Treatment. And we will have today, it's a bridging session, so data from the lab going to the clinic and also vice versa, clinical observation from early infection leading to understanding HIV pathogenesis. So we have the privilege to have a large panel that cover viral determinant, immune response, and a treatment effect. And I think it's a privilege to be here and to co-chair this session. Maybe, Ezier.
Yes. Hello, welcome to the bridging session. My name is Sáez-Cirión from Institut Pasteur. And so we are going to start right away. And
Lydie Trotman from the Walter Reed Army Institute of Research. And Lydie is very well known for understanding the T-cell exhaustion, and she pioneered with Rafik Sekali when she was in Montreal that PD-1 expression can be blocked and coming back some function after inhibition. And she focused now her work on CD8 and the effect on viremia and also on HIV reservoir during early phase of infection.
Thank you, Jean-Pierre. So it's my pleasure to be here in Paris. What a beautiful city. I'm happy to be back home. And thank you for the organizer to giving me the opportunity to share the data on immune responses in acute infection. So as Christine has given a very nice overview of the reservoir, what I'm going to do is to show you what new insights we have in terms of immune responses and talk a little bit about this impact on viral reservoir. So I have no conflict of interest. So understanding the immune responses in acute infection is very important because every event that occurs very early in the battle between the virus and the host really dictates what's going to happen in chronic infection, but even under ART. So in the first days of infection, the CD4 T cells are mainly infected, and as they fuel the infection, they get depleted from tissues and eventually lead to systemic inflammation. And in part, this is due to microbial translocation in the gut and really a cytokine storm and a lot of inflammation happening in acute infection. As the immune cells get exposed to a lot of antigen and try to fight against the virus replication, they become exhausted, and a lot of work has been shown to demonstrate the expression of immune checkpoint blockers, as we call them now. The first one was PD-1, but many others have been shown to be expressed on these immune cells, and we call them exhausted in the sense that they're not able to respond to the virus as potently as before. And a lot of work has been shown in acute infection or primary infection, I would say, looking at the responses directed to specific peptides and have shown that very early in acute infection, the virus is actually escaping the pressure and is mutating. So the acute infection is divided in different stages, that you can see here. Each stage is only a couple of days, and this is very important to remember. The first stages, Phoebic 1 and 2, are really the first stages in the first days of infection before the peak viremia. Stage 3 is at peak viremia, and then the stage 4 and 5 are later during the acute phase. And most of the work describing the immune responses in acute infection have been actually done in these later stages in Phoebic stage 4 and 5, just because of the accessibility of samples, and that has been published during the last 20 years. Recently, a very nice study done in the FRESH cohort, which is a cohort in South Africa of women that are followed regularly and captured within days of infection, have shown and characterized the HIV-specific T cells in these early stages of infection. As you can see here in that graph, the activated CD8 T cells, which have been shown to be mainly HIV-specific, arise in the early phases of infection within days following viremia. And then, importantly, what the authors have shown in that study is that the frequency of those activated cells in acute infection at their peak was negatively associated with the viral load set points, but also the rapidity of these responses to emerge, as you can see on the right graph here, the days to peak, were also associated with viral load set points. And these data suggested that actually the rapidity and the strength of those responses in acute infection would lead to a better control of the viral replication. As I mentioned before, the days matter, and this is the RV217 cohort from the US Army, and these people are followed twice a week in Uganda, Tanzania, Kenya, and Thailand, and they are recruited within days of infection again, and they are sampled very frequently, so we can really determine tightly the course of the viral replication in these early stages. And as you can see in this graph, the peak to viral load between the days of the first plasma viremia and the peak is only 13 days. So now we know that we really have to understand what's happening in those first 2 weeks of infection, and we don't know a lot about these immunological events. And again, as many studies have shown before, you pass the peak of infection after only 14 days of infection, and then the immune responses starts to be dysfunctional. And this is illustrated in that graph here. So after peak viral load in acute infection, the immune responses become to be dysfunctional, first by a hyperactivation and a dysfunction, and eventually an exhaustion and a higher expression of immune checkpoint blockers and other mechanisms of dysfunction. But what was hypothesized in 2010 was that there could be a window of opportunity very early in acute infection, prior to peak or at peak, where the immune system would not still be dysfunctional. And if in that window of opportunity we would initiate treatment, then we could preserve that immune response. So this is really what I'm going to talk to you about now, is what happened to the immune responses in those very early stages, FIBIC 1, 2, before peak, and at peak in FIBIC 3, to the immune responses, and whether we can, if we treat at that time, can we preserve, and would that be enough to then lead to control? And so that's the opportunity that we had in the MHRP Search 10 RV254 cohorts, where the individuals in Thailand are captured within days of infection, and when they're enrolled, and the enrollment between the testing and the enrollment is very short, is only 1 or 2 days, they initiate treatment right away, and then they start treatment, and they are followed longitudinally for years. So in that cohort, we have access to blood samples, but also to tissues, where we can even interrogate what's happening into tissues, because really the infection, especially at the beginning, is doing a lot of things in gut tissues and lymphoid tissues. So Nicolas Chaumont and Louise Lair looked at the HIV reservoir in those different stages in the RV254 cohort in acute infection, and he showed that this graph is showing prior to treatment, so in acute infection. You can see that only the FIBIC 1 individual have a lower HIV DNA content in their cells than the other stages, but overall they have similar levels than in chronic non-treated infection. So really not a lot of differences at acute infection, except for the FIBIC 1s, which are the earliest. After treatment, the picture is different. You have a significantly lower reservoir size as measured by total HIV DNA, but this is also true with integrated HIV DNA. In all the acutely treated patients in the FIBIC 1, 2, 3, and even the later stages, compared to people that have been initiated treatment during chronic infection. You can see here that there is, again, not a lot of differences between the later stages of infection, and only the FIBIC 1 are almost all undetectable by that assay. So they have a very, very small reservoir. So what we wanted to know is whether very early ART in acute infection could preserve immune function, and whether these better functions could impact the HIV reservoir. So we looked at the B-cell compartment, and Elias Haddad and Rochelle Muir looked at the resting memory compartment in the blood, and that compartment is impacted in acute infection as early as the stage 1, 2, if you compare to the uninfected here in light blue, but it's even lower frequency in the stage 3 at peak viremia. However, when we initiate treatment in acute infection, the resting memory B-cell compartment recovers to normal levels compared to uninfected individuals. And that's lower in the chronically treated individuals that initiated treatment at a later stage of disease. So the early treatment seems to preserve the resting memory B-cell numbers. He also looked at the function of the CD4 T cell subset, which is providing help to the B cells which are called the CD4 T follicular helper cells, or TFH cells. And he does that by a functional assay, where he co-cultures these circulating TFH and B cells. And what he showed, and you can see here on those two graphs, is that the CTFH cells are not able to provide good help and lost their function to provide B cell help in the stage 3 compared to the stages 1 and 2 in acute infection, as measured by lower production of total IgG and HIV-specific IgG in the stage 3 samples. So even at peak viremia, there is a loss of function of those circulating TFH cells. So as TFH cells are not circulating too much in the blood, but are mainly in the lymph node, we had the amazing opportunity to look at lymph node tissues at these earliest stages of infection. And as you can see here, we looked at their expression of PD-1 and CXCR5 in the dot plot represented on the top. We could see that actually in acute infection, in all the acute stages of acute infection, we didn't see an increase in an apparition of those TFH cells in the lymph nodes compared to uninfected individuals, again in the light blue. We had a slight increase in some individuals at stage 2, but really it didn't continue to increase, and at stage 3 and 4, we had very similar levels to uninfected. And we had a lot of TFH cells, on the contrast, in chronic infection. When we correlated that numbers to the frequency of germinal center B cells in the lymph nodes, we could find a very strong correlation between the presence of those TFH cells in the lymph node and the frequency of germinal center B cells. So that suggests that actually only the individuals that are able to mount some TFH cells in the lymph node are actually generating germinal center B cells, but in the majority in acute infection, we don't have that generation. So even in acute infection, we were able to see that there is actually effect even earlier in acute infection for the TFH compartment. We also looked at the HIV-specific CD8 T cells, which are the cells that can kill HIV-infected cells. And the way we do that in acute infection is looking at activation markers. Here I'm representing Ki67, a proliferation marker, and BCL2. And looking at that, we have also shown that most of those cells are actually HIV-specific. And we could see that there was a slight increase in stages 1 and 2 of those cells, effector CD8 cells, compared to uninfected, but really not continuing to expand. And really the higher expansion was only seen at stage 3. When we looked at the differentiation of those cells into effector functions, we could not see an increase in the stage 1 and 2, but only in stage 3, they start to express TBET, which is a transcription factor for their function, and also the perforin, which is the effector molecule, that is only significantly increased at stage 3. So we observed a delay in the differentiation of those HIV-specific T cells. So one argument we could have here is that we're looking again in the blood, so would that happen earlier in the tissues and then come a little bit later and recirculate in the blood? So we looked again at lymph nodes in acute infection, and we could see exactly the same delay in the lymph nodes that we observed in the blood, which is that we have a slight increase of activated effector CD8 cells in the stages 1 and 2, but not much to the extent of what we see as expansion in stage 3 and later stages. We also looked at effector molecules, and it was the same delay that we observed there. And when we compared the responses of effector CD8 cells in the lymph node and in the blood, we had a very strong association suggesting that those cells are recirculating, and really what we see in the blood is reflecting what is happening in the tissue for these HIV-specific T cells in acute infection. So we were wondering whether those cells that are expanding, at least in the stage 3, could influence the viral replication in the reservoir. So we looked at 2 weeks after treatment, where the viral load is not completely suppressed, but we can see a decline of viral load if you look at the week 0, which is the acute time point when the individuals initiate treatment, and 2 weeks after initiation of treatment. And you can see that those slopes in the different stages, the red is stage 3, the green is stage 2, and the blue is stage 1, they start with different plasma viral load, but they also decline at different rates. And so if we looked at the fold change between the plasma viral load at week 2 to week 0, and we correlated that with the expansion of those effector cells, we could find a strong association. And represented here is actually the expression of perforin, the effector molecule, which also correlated with the slope of decrease of this plasma viremia. So this is suggesting that those cells that are expanding and differentiating into fully effector cells are actually contributing to reduce the viral release after treatment initiation. But the counterpart of having fully effector cells that can kill and decrease viremia is that they start losing their survival capacity, they become short-lived. And so that's what we see when we look at Annexin-5 here in the left panel of the slide. You can see that those cells start losing their ability to survive with a higher Annexin-5 staining, which is a marker for dying cells at stage 3 compared to stages 1 and 2. And also they start losing their polyfunctional ability by secreting 2 or 3 cytokines while the viral load is increased. So those effector cells are fully differentiated, but they are short-lived. And this is really seen in vivo also. So that was in vitro, the Annexin-5. But in vivo, what happens is that if you follow those HIV-specific CD8 T cells from the baseline in acute infection to 2 weeks after treatment, you can see that in the FIBIC 1 and 2, they continue to expand for these 2 weeks with an increase in their frequency. However, in the stage 3, where we have those fully differentiated, short-lived effector cells, they start contracting right away. And 2 weeks after starting treatments, they really reach the similar levels of frequency. One thing that I would like to point here is that even though these effector cells in stage 1 and 2, so the red and the green, are continuing to expand, they never reach the level of differentiation and expression of effector molecules than the effector cells that are here. So they are continuing to expand, but they're not differentiated to the same effector, potent effectors. So we looked at the impact of those effector cells on the seeding of the reservoir, and we didn't look at the stages 1 and 2 because, again, they're not really fully effector cells. But for the stage 3, who were fully differentiated in the acute phase of infection, when we look at those cells at week 2, so when they are contracting, we could see an association with the size of the reservoir, with higher frequency of those cells still persisting at week 2, the lowest the reservoir, and this is showing at week 36 after treatment initiation. So that means that the cells that are able to survive the contraction a little bit longer and persist during that first decay of the virus are actually reducing the seeding of the reservoir. So one thing that we were wondering is whether if we treat that early, we would preserve any memory, and would that memory be preserved also that compared to chronic infection. So the way we look at memory HIV-specific CD8 T cells is by tetramers, because in memory phase, these effector cells are not activated anymore, and they are at very, very low frequency. So we have some dominant tetramers that we use in that cohort. And as an example here, you can see one tetramer staining for one patient that was treated in FIBIC 1 for 5.5 years, and we can detect low frequency but specific cells for this A11F peptide, and we can phenotype those cells. And here we use memory markers for the memory subsets, as well as IL-7 receptor as a marker of survival potency, and perforin, which is the effector molecule. When we looked at that, this is a summary of the data. If we compare with influenza memory CD8 T cells, their phenotype in the memory phase, of course, not when you have influenza infection, but in the memory phase, they are 100% central memory phenotype. They express 100% IL-7 receptor. On the other hand of the spectrum, the HIV-specific CD8 T cells in the memory phase, or on ART, in people that have started ART in chronic infection, are all in the transitional memory subset. They express low level of IL-7 receptor and some levels of perforin. When we phenotyped the HIV-specific T cells in our acutely treated individuals, what we found is that they were in the middle. So they were not completely comparable to the memory cells compared to influenza, but they were not compared to the HIV-specific cells in chronically treated individuals. And we observed a range, and again, I didn't cut here between the stage 1, stage 2, and stage 3, But we have a range between 100% to 60% of IL-7 receptor expression and between 100% of central memory to 50% of that subset. So definitely they're preserved and they have a different phenotype than when people are treated in chronic infection. So what these data told us is that very early ART initiation limits the reservoir seeding either by limiting the viral burden when we treat prior to peak viremia, and this is mainly true for the FIBIC1 and even the FIBIC2, where the immune responses is still not able to control a lot, but just the viral burden is lower, so the viral reservoir is low. Also, if we treat at peak, it preserves potent effector cells that are able to reduce the viral load and reduce the seeding of the reservoir. So the outcome of that treatment, either of the two mechanisms, is that if you look at the reservoir of people that have been treated in acute infection, if we take the FIBIC1 aside because they have a lower reservoir, but if we split the acute infection between the different stages, there is not really differences between the different stages. One thing we didn't look at is whether these different stages have different functional reservoir or replication competent virus. That we don't know. But if you look at the total HIV reservoir in those different stages of acute, the size is roughly the same. The picture is a little bit different when we look at immune responses, and this is why now we are at a stage where we don't say acute infection, but we have really to segregate and be a little bit more specific into the phases of infection, because very early treatment in acute infection for the immune responses can preserve overall the resting memory B cell compartment, but also can prevent, if we treat early enough in stages 1 and 2 only, can prevent the impairment of the CTFH-dependent humoral responses, and also can maintain HIV-specific CD8 cells with a higher memory potential. But what I would like to highlight here is that the early treatment is not enough to preserve and to have a fully functional immune response, even at these early stages. And we know now that even with the FIBIC1 treated that have the best immune responses and have preserved immune responses, that is not enough to control the virus if we start treatment. So what we learned so far is that we have, when we talk about immune responses in acute infection, we have to actually be a little bit more specific, and we cannot globally take all the patients because the responses are different in the different stages, and the impairments are also different if you look at those. And again, it's only a couple of days, but the differences are huge. And so to summarize, what I would like you to take home as a home message is that if you look at the HIV reservoir, if people are treated in acute infection, they will have a low viral reservoir compared to chronic infection. And they would also have some preserved immune function, not perfect, but better than the immune functions that they have when treatment is initiated in the memory phase. So we think that there is a dysfunction that occurs even in the earlier stages, and that dysfunction will also happen again if we stop treatment. So we really have to use these patients to develop immune-based strategies to help that preserved memory, to control the virus replication after post-treatment control, because just treating will not be enough. But we think that this group of patients that have a lower reservoir and a better immune response is the best cohort to start and to be able to understand the mechanism and then develop some immune-based responses that can be applied to the bigger group. And with that, I would like to thank all the search team and the RV254 study group. Some of them are here today. The RV254 participants, the collaborator on the RV254 study, the founders. And I would also like to thank the leadership and my colleagues at MHRP and the cellular immunology section, in particular Hiroshi and Suprani, who have done the work I presented at RARE. Thank you.
So very, very nice data, and so hard to collect such a very early cohort. So just a general question. If the peak predicts the set point, can immune event occur before the peak, and then CD8 would take stage 3 to mature or to have performing? So does something occur before the peak?
Absolutely, you got it, Jean-Pierre, this is exactly right. we think that actually we have to start, of course we cannot study the immune response in the eclipse phase, but we think that key events occur very early in infection that are really preventing this start of immune response to be generated the right way. And that will impact then the expansion of those CD8 T cells. And the people that are able to respond faster and so have these early events better would have bigger peak and would eventually control better. But this is really the key here is those very early immune events that we don't understand yet that are really even dictating what's happening at peak.
Question?
In any case, we are running a little bit late, so we are going to pass through the... Oh, yeah, no, we are going to pass. If we have some time at the end, we will, because we are actually running quite late. So it's my pleasure to introduce John Frater from University of Oxford. As you all know, John has been informing us with very nice data coming from the Spartak trial, and he's interested in understanding the establishment of reservoir and how treatment during primary infection can affect the reservoir and also the immune responses.
Thank you very much. Good morning, everybody. You've heard two very elegant talks explaining what happens to the immune system and the reservoir when we start treatment. And I've been given the brief to say which treatment during PHI and for which results. And actually, for the sake of sanity and for the sake of time, I'm going to trim that down to a more simple title, because there are two questions in there, and I think I want to focus on something a bit more specific. And I'll explain why. So, treat PHI, yes, of course. But I really want to drive in and explore that question of why we want to do that and put a clinical context on some of the really elegant data you've just seen in the last two talks. So why can I just say yes, of course, for treating PHI? Well, we all know this now. Since 2015, we know data across the board suggests that everyone living with HIV needs to be on antiretroviral therapy, and this is supported by fantastic trials such as the START trial. But I think just a bit of context there. Yes, of course we treat PHI, but the data that are driving this evidence are from chronic infection. And so we just need to question ourselves, is PHI different in some sort of way? So we're going to treat it, but do we need to think slightly differently about the objectives we want to achieve? And in doing a bit of research for this talk, I found this editorial from 1996, 21 years ago, from Sabine Kinloch and her colleagues, suggesting that primary infection is actually a medical emergency. You have a discrete window of time in which you can make a difference by starting antiretroviral therapy, which you would not get if you waited into a more chronic phase of the infection. I was slightly amused to find that Sarah Fiddler and Julie Fox, two of the real experts of treating PHI in the UK, wrote pretty much the same editorial 20 years later with pretty much the same title, which suggests that people aren't really listening. And this is something we need to kind of push a little bit harder. So what are the basic reasons clinically and immunologically and scientifically why we want to start therapy in PHI specifically? And some of these are pretty straightforward. To enhance immune recovery, and we've already seen data on this. Restoring CD4 T-cell immunity, we and others have shown that. This concept of improving the CD4-CD8 ratio, and I think I'm not quite sure what this unitless number actually means, but it seems to be telling us something really important. And when we see our patients, it does seem to correlate with good things. So I think understanding this is important. Limiting the risk of onward viral transmission, and I think this is one of the critical reasons, actually, why you're going to start treatment in PHI. Because we're not just worrying about the person who's living with the infection, but we're worrying about those contacts and the bigger public health message there. And I think that there's mathematical modelling now that is just so evident, and other data that is so evident that if you treat early, you really can make a difference to transmission rates. And then the third reason that we talk about treating in primary HIV infection is to limit the size of the reservoir. And this is actually the one I want to concentrate on a bit more, because I want to come back and just ask that question, to stand back for a second and say, well, does that actually matter? And I'll tell you why I want to ask that. Just to manage expectations in the audience, what I'm not going to discuss is how many antiretrovirals we should be using in primary HIV infection. And I think there's good data already out there from people like Marty Markovic, the Optiprime study, saying, 3 is certainly plenty, you don't need more than that. We might debate it if you want fewer, but certainly I think we know that you don't need to be adding extra drugs in at this stage of infection. I'm not going to be talking about which classes of antiretrovirals we should use. above and beyond to say that there is pretty good evidence now from Flamingo and the Startmark study that if you have an integrase inhibitor as part of that initial regime, you're going to bring your viral load down faster. And if we're thinking of this as a medical emergency, as a discrete period in which you need to act quickly, that dynamic of bringing your viral load down faster might be important. I think we need longer-term clinical data to support that finding, but at the moment I think it feels like a strong hypothesis. And I'm not going to talk about other interventions, the HDAC inhibitors, the BITEs and the DARTs and all these things we've been talking about at the CURE meeting, which might do something else that's quite special in primary infection. I'm going to concentrate on this. Why do we want to reduce the HIV reservoir size? So we've already seen this data from Christine's talk, but I think the first thing is just to sort of underpin that statement, that if you treat early, you do make a difference to the size of the reservoir. And this is Laurent Occlu's paper that has been data that's been shown so many times that you need at least nearly a log-fold drop, and it happens really early. We conducted a trial called the Spartak study where we again treated in primary infection, and we saw the same sort of effect. We see an early effect within 12 weeks in the green dots there. You're already starting to see nearly a log drop in the size of the reservoir, which you don't see when you treat in chronic infection. So it does make a difference if you can get in early. And why does that matter? So these are data from people who are not on antiretroviral therapy from the Spartak cohort, because in that study there was a randomization. We couldn't do this now, but there was a randomization where some individuals were randomized to receive no antiretroviral therapy, the standard of care arm. And we could measure the reservoir at baseline in these individuals and see how long it took for the CD4 count to progress to 350 or to starting therapy. And here the graphs are divided at the median into those who had high and low reservoirs measured by the total or integrated DNA. And there is a clear dominant message here that the people who have high reservoirs progress in their disease if they're untreated much more quickly. And we all know the fantastic data that John Mellors produced all those years ago saying viral load is your key marker of progression. Well, in primary infection, when you do the stats and the multivariable analyses, the viral load drops out. It is the reservoir that is the key driver of progression in primary infection, so a valuable thing to know. But it's a valuable thing to know if you're not on therapy, which isn't the situation we're in anymore. So the question that we have now, where we're treating everybody, is if you're on therapy, why does your reservoir size matter? And I think there are two ways of looking at this. What impact is that going to have on your outcome on drugs? On your morbidity, on your non-AIDS morbidities, on your lifespan? And then the other sort of more aspirational question is what potential then for cure or remission? And I just want to spend a few minutes in the limited time we have talking about both. So in terms of morbidity, the way I see this is at the moment, if you're not on therapy, we have these two markers. We have your plasma viral load, we have HIV DNA, and these are nicely distributed across your population. Some are low, some are high, and we have good evidence that if you have a high level of either of these, this is a bad sign in natural disease, and you need to do something about that. As soon as you start therapy, we're taking plasma viral load out of the equation. It is undetectable in everyone, we hope. But you are still left with a distribution in your treated population of HIV DNA. So some of your patients are low, some are high, but they are all undetectable. And the question there, when you're looking at your patient, is does this actually matter? What impact is this going to make over the next 10 or 20 years in terms of their progression? And I would argue, actually, we don't know the answer to that question. And I think it's extremely important to try and find out. But we have some circumstantial evidence, and we've heard some of this already, that suggests it might be important. So we've shown data again from Spartak that HIV DNA is closely correlated with markers of immune activation. It's closely correlated with markers of T-cell exhaustion, PD-1, TIM3, TIGIT, these markers we've been hearing about. HLA-DR, a marker of activation, also correlates with your reservoir. And nice work from John Thornhill is also showing the same sort of thing is being found in tissue as well. And then we have this concept of the CD4-CD8 ratio, which we have just seen is well preserved if you treat in primary infection. Numbers above 1, which you don't see so much in chronic infection. And this number correlates with the reservoir size. It is associated with non-AIDS morbidity, and it associates with immune activation. A number of people have shown this in different studies. And the fact that all these things have been found feels like this is going to tie together somehow to suggest that your reservoir size does matter. So just to sort of underpin some of that, this is, again, work from John Thornhill, showing that your CD4-CD8 ratio correlates really nicely with HIV DNA. And this is from patients in primary infection and chronic infection. And when the multivariable analyses were done to say, well, which are the markers that really impact your HIV DNA level, the things that remained, aside from taking out things like time from therapy and all these other variables you might think about, it was whether you were treated in primary infection and your CD4-CD8 ratio were the main predictors of your HIV DNA size. So these are all sort of circumstantial bits of evidence. There's something to say these things all fit together. So we can start to build up a bit of a model, a bit of a picture. And we talk about reservoir size. I think there's another concept here that we might want to sort of borrow from our colleagues in hematology about minimal residual disease. Because we talk about reservoir, but actually, when we have individuals on therapy, what we're really talking about is this residual disease burden, this sort of remnant of what the HIV has left behind within the body and how that might impact. So reservoir is one term, but I think there is another sort of conceptual way of thinking about that above and beyond what we think about for cure. And there are a number of questions we need to ask around this, which I think we don't know. How does this link to chronic immune activation? I think there is growing evidence that there is an association, but I don't think it's proven quite yet. And then if that is true, how does that link in terms of those biomarkers we might want to measure in the clinic to help us predict outcomes? These are all available, they all look very interesting, and I think we're going to get growing evidence that it's something we might want to know on our patients receiving therapy. And then what is that final outcome in terms of long-term outcomes, in terms of CD4 recovery, and then proper non-AIDS morbidity and real ability to progress and stay well and have a normal lifespan? And that probably all does link up. I'm going to finish off then on this other thing we want to worry about, remission, and its potential to induce this. And this is complex, it's controversial, and there are lots of confounders. But it's real. And actually, you know, people like Christine, Assier, myself, and this is a bit of a shout out to the European researchers who've been saying for years that if you treat in primary infection, you can achieve remission for a period. And, you know, the Visconti cohort is a fantastic example of that. So it was really good to hear Dr. Fauci in his excellent talk yesterday come on board with that idea and start saying that remission is something that is there and that we need to think about. So it's good that he's caught up with us. So these are data from Spartak, just to sort of emphasize that point. Where people were treated either for a year or for 12 weeks and they stopped in primary HIV infection. And really, there's one piece of data on it you to take from this slide. Where it says greater than 12 weeks, that's a year of therapy. Less than 12 weeks is around a year. So 2 treatment interruptions. But yesterday we heard in that plenary that, you know, some people were still in remission after 4 months of therapy. This is after a year. So a year after stopping 12 months of therapy, 14% of our patients with Spartak were still undetectable. And I presented this slide loads of times, and actually it still strikes me as quite remarkable. You do not see that in chronic infection. It is a very striking result, and I don't think we understand the mechanism of what is really driving that, but it is unusual. But just to put some sort of caveat and some definition on this concept of remission, there are different types, and again we need to nut some of these out. We see transient remission, and we see this again in primary infection where you start therapy, and if for some reason you stop, there is a period, and here's some data from Genevieve Martin, again from Spartak, showing that you will eventually get rebound in the vast, vast majority of these individuals, but it may take 2 years before rebound occurs. Again, why is it 2 years in some, and why is it a few weeks in others? And then we have other individuals, for example, the Viscontis that we know so well, and this case from Sabine Kinloch with real, what looks like proper post-treatment control, where treatment is started in primary infection, it's stopped, and then the virus does not rebound. 10 years out still, and we're hearing similar stories from Visconti. And this is remarkable. And when we're talking about all these this baby being cured and other things like that, these individuals are looking really, really interesting. We really need to invest heavily to understand what is going on here. But I want to put up a quick health warning, because these data tell me that if you're going to do an intervention study and you want to add something into therapy at primary infection in terms of inducing cure or extending time to rebound, the marker that we think is the gold standard for cure, you have to do a control, because there is so much variation on treatment alone that unless you do that, using a historical control is going to make any interpretation of your data extremely difficult. And to add an extra layer of complexity on that, I want to point out that even if you don't treat in primary infection, you also see a period of what can look like remission. So if we talk about 4 months as a period that might be interesting, in those patients in Spartak who did not have therapy, 8% of them had a period having peaked and then come down spontaneously after their primary infection of at least 16 weeks without the virus being detected before they eventually became detectable. So again, this is another layer of complexity in understanding how we're going to look at treatment interruption in future studies. But remission is there, and we need to understand what drives it. We talked about lowering the reservoir and we've talked about remission. Are these correlated? Well, they are. And again, there's different data around this, but there's a growing body of evidence from Spartak, from work on the ANRS, and from Jonathan Lee in the States, saying if you measure your total DNA at the point of treatment interruption, it is actually a very good predictor of time to rebound. And here, again, data from Spartak showing that people who had the low DNA levels when they stopped therapy here had a much longer duration of remission. In this case, they all rebounded, but there was a greater duration of remission. So again, this is important. So I'm going to sum up there. Treat all PHI with antiretroviral therapy. I think that's a no-brainer for all of us now. People need to be on these drugs. There are lots of other exciting experimental and hopefully safe interventions that we can also use. We're doing the RIVER study in London where we're giving an HDAC inhibitor, vorinostat, with a vaccine to see if we can make the reservoir even smaller, and there are other interventions occurring across the world, and these will be really interesting to see if we can make a further difference to the reservoir. There are multiple benefits of treating PHI, but I just want to underline this issue about urgency. You need to get in quick, and it's been said in the other two talks as well, that there is a time window that probably makes a difference that we need to act on. And then, why do you want to know the reservoir? Intuitively, it feels like a good thing. You want to have a smaller reservoir in your individuals on therapy. And it's just it's kind of feels like that's just right. But actually, I would argue we don't have the clinical data yet to support that. That would be really important, I think, to find out and to help that understand how we can monitor our treatments better. Possible link with clinical outcomes on CAR, that needs the data. And then we have this association with remission, which I think is really exciting, especially in this current era where we're trying to dig hard into what might be driving cure and mechanisms behind it. So I'm going to stop there. I'm going to thank my fantastic group in Oxford who work incredibly hard and produce wonderful data. The participants, mostly though, of all the studies, Spartak and Heather, who come in and have frequent blood draws. All my colleagues across London and elsewhere. The Cherub collaboration, this group across the UK who work together towards HIV cure, a fantastic group of individuals with a very common, passionate theme. And also our funders. And I picked a little shout out to the British HIV Association, who has been funding research like this for a number of years, very generously supporting young researchers across the UK, and I hope they carry on doing that. So I'll stop there. Thank you.
Time for one quick question. Can you go to the microphone?
Where is the microphone?
This in the middle.
No?
No, this one question. Just on the meantime, when you are talking about lower levels of reservoir, and this is something observed in transient remission or more long-lasting remission, we are not talking about dramatically low levels of reservoir. It's now undetectable in PBMs, etc. So probably that means that this is not just a matter of getting rid of as many cells as possible.
Yeah, no, absolutely. No, these levels aren't ridiculously low. I mean, they're within your normal distribution, and yet there is value within that distribution itself. So at that bottom end, within highly measurable levels, it still has an impact. So yes, so there are other factors. It is multivariable, and we don't know the other factors yet.
Hello.
Hi.
Hey, wonderful presentation, quite educative. I'm Dr. Kafunya from USA Discover Health Project in Zambia. I'm very interested in the concept of remission. I know you said you wouldn't talk about the drugs and the dosages, but it begs the question to say if we can simulate or bring about a situation or a presentation of something like remission, don't you think we can also start talking about how much drugs would be needed or how much dosage would still be needed in a patient who started treatment in primary infection?
Yeah, and I think that is a really excellent question. To be honest, the data aren't out there. Yeah. So I think there is this issue of what it is that drives the different variable levels of remission. And is it due to which drugs you were on? Is it due to how quickly that viral load came down? Is it due to penetration, in tissue sanctuaries or the brain or somewhere that we haven't really thought about? Now, there are some agents that are going to do that better than others.
Okay.
At the moment, your question is the right question to ask, but we don't have the data yet, I think, to answer that, but I think that this is exactly the sort of work we'll be doing. I mean, one end of that is to say, if you have an undetectable viral load in the plasma, that's enough. And so lots of regimes will do that for you. But there's the other sort of the detail within that, saying, can you do that slightly better by introducing a different drug class or something? And I don't know the answer to that. I think it's important.
Yeah, maybe something to think about.
Lovely. Thank you.
Thank you. So it's my pleasure to introduce Jintana Tanangwaranic. Jintana, I will say that a few years ago, kind of revolutionized the way we think about studying primary infection, and we are not talking about primary infection in the same way, or at least acute or super acute infection. And Jintana has been doing incredible work with this work of with this cohort of individuals in Thailand, both in the immune part of the analysis, the virological response, but also about the identification, the testing, the counseling, and this is a very incredible vision for research.
Thank you so much for that introduction, and it's a great honor to be here to speak with you about this topic. So in the next 15 minutes, I'd like to first talk about our study, the RV254 acute HIV infection cohort in Thailand, and particularly how we screen for acute infection. I'll talk a little bit about what other methods are available, and then in terms of HIV remission trials, what we have learned and what are some considerations that we could think of for future trial designs. So I hope that this will be useful in your work, and I do look forward to input either by questioning at the time of Q&A or afterwards on how we can better design our future remission studies. So the RV254 Search 10 study began in April 2009 in Bangkok, and this is a collaboration between the U.S. military HIV research program and the Thai Red Cross AIDS Research Center. And we have screened now, you can see, over 230,000 samples. And these samples are from clients who walk in to the Thai Red Cross Anonymous Clinic, which is the largest HIV testing center in Thailand. They are identified very fast, get their diagnosis confirmed, and the team really in Thailand works amazingly fast in enrolling participants and offering treatment immediately, and our participants start treatment the same day or the next day. And you can see that the majority are young MSM. They've been infected for about 2 to 3 weeks. Actually, 40% are in the earlier stages of acute infection when they're still seronegative. And our participants are very adherent to treatment, and the viral load suppression rate is quite high, even 3 years or more after treatment. So this is how we screen for acute infection. When someone walks in to the Thai Red Cross Anonymous Clinic, the standard test that people get is the 4th generation antigen-antibody combo assay. And as you would expect, that most people who come for testing will not be infected. So the non-reactive test results are more, and then about 16,000 people, however, tested reactive to the 4th generation assay. And so they would get confirmatory testing, and this would all be done while they're waiting in clinic. Now, if we didn't do acute HIV infection research, the testing would end there. But in our study, we incorporate other types of testing. So in the arm of the people who are reactive to the 4th generation immunoassay, we do a less sensitive immunoassay that detects IgG, and this test becomes positive later in infection, later than the 4th generation. And you can see here that the majority of people who test reactive to the first test will test reactive the second test as well, and they have chronic HIV infection. But we did see over 400 people who actually test non-reactive to the less sensitive test, indicating that their infection is probably more recent. Now, in the arm of the people who test non-reactive to the 4th generation, we did pool nucleic acid testing, and the size of the pool depends on the number of samples on each day. And so the majority are negative, so they're uninfected, but we did see over 140 people who tested positive with the nucleic acid testing. So this represents a very early and very recently infected group of people. And you can see here that we've identified over 580 acutely infected participants, but we've enrolled about 100 less than that. This is because this is an anonymous testing center, so we would require people to give a contact phone number or a nickname at the beginning in order for us to contact them. So what might be other ways to identify primary HIV infection? And I think one of the best ways is really to have high suspicion of someone that might have HIV infection. People who come in with febrile illness, we should always ask about history of possible HIV exposure. And even if the test is negative, then they should come back within a week or two to get a repeat testing. Now, several cohorts, including the military RV217 cohort, have looked at people who are at risk of HIV infection and then do prospective screening. In the case of RV217, nucleic acid testing is done twice weekly, but I think that with the advent of home testing, we now would have the opportunity to perhaps institute frequent home testing that could perhaps identify people who've been infected within the past month. There are also other testing that are now being used more. For instance, the Genius HIV 1-2 testing. Here you can visualize the bands. This is done in 30 minutes. So if you have someone who comes in and tests reactive to an HIV antibody test, rapid test or other test, but they have indeterminate or negative Genius tests, that indicates that this is recent infection. So now I'd like to talk a little bit about early ART and HIV remission trials. And so far in RV254, we have done several HIV remission studies with or without interventions, and we've had a total of 40 people who have interrupted ART within these trials. And you can see this is time to viral load rebound over 20 copies. And you can see that almost everyone rebound fast. The median time of viral load rebound was 22 days. So at least in the setting of Thailand with a CRF01 AE infection, looking at time to viral load rebound, we did not see early treatment being associated with the ability to delay time to viral load rebound. Now, we also wanted to see whether starting treatment at FEBIC1, which is very early, versus later stages in acute infection, had something to do with time to viral load rebound. And here you can see the days to viral load over 20 copies on the y-axis. We do not see a big difference between people who start very early versus later acutes. We also look at total HIV DNA in the CD4 T cells on all these participants versus days to viral load rebound. And there is no statistical significant association, although this may change. I mean, eyeballing the picture, it looks like whether if we have more sample size, would we see an association like people has seen in other studies. Now, we've been asked whether looking at time to viral load rebound is the right endpoint. And how we have done our studies would be to give immune interventions, and then because biomarkers for viremic control is really not known, and in RV254, people have such low reservoir already, so if we give intervention, we can't really see a difference because it's already low at the beginning. So we incorporate treatment interruption as a way to measure efficacy of intervention. So we expect that some people might control, but most people actually rebound quite fast. And in our studies, we use viral load over 1,000 as a criteria to reinitiate treatment. And so there's been discussion whether this is too early. And we have not let people really see whether they would control themselves. So a new idea is that whether we should let people, particularly early treated people, who have low frequencies of HIV-specific immune response at the beginning, But if they were led to have some viremia, which would stimulate the HIV-specific immune response, whether they would actually control. And I think the difference between our studies and the Visconti as well as Spartek is that people are off for such a short time, and we restart so early, and we are not able to see whether people can get to what the other studies have seen. And so we're really thinking about this, whether to incorporate this in our future studies. So what we want really when we have someone with early treatment and their viral load suppressed is really to be able to have immune surveillance that is persistent enough that could eliminate cells that become reactivated and start to produce virus. And so, as you heard Liddy also, that the frequency of HIV-specific CD8 T cells are rare, and actually the frequency of cells that are latently infected are also rare. So how do they find each other, and how do we help the immune system be able to gain better control in terms of clearing infected cells? So there are many exciting interventions that are being studied now, as well as many novel delivery systems that could potentially reduce the dose that is needed by perhaps BNAbs and other things, and reduce the frequency of giving these interventions by several magnitudes. So if we look at the interventions in the context of acute HIV, when might we intervene? So here is a graph of a viral load. After acute infection, if we start treatment, the viral load comes down very fast, but once we stop treatment, in most people, the viral load will return. So we could think about trying to intervene very fast at time of ART initiation during acute infection, whether with vaccines, broadly neutralizing antibodies, latency reversing agents, or combination. And here we want to reduce the viral load faster and induce more killing of infected cells, with the hope that eventually we can help people control viremia without needing to take daily medications. We could also intervene later when people are viral load suppressed. But here, I think that we would need an additional immune adjuvant or latency reversing agent to make the immune interventions, which is vaccines or BNAbs, more effective. So what might be some potential trial designs? And this is just an example of a combination BNAb design, and I'm assuming that the future BNAbs can be given less frequently. So you can imagine that you have someone diagnosed in acute infection, and they're randomized to getting additional broadly neutralizing antibodies versus ART alone. And they would get BNAbs probably for about 24 weeks, then get treated about a total of a year on ART, then reconsent whether they would want to go through with treatment interruption. And I think as we do more studies giving experimental agents at time of acute infection, reconsenting for treatment interruption is even more important. You cannot expect people who have just found out they just had HIV infection to be able to think straight and think whether they would be agreeing to treatment interruption a year later. They might get a few more doses of the intervention, and then while they interrupt treatment, and then the criteria to resume treatment will depend on what the criteria of the study is. And so even with this design of 45 people, this is actually quite a large study if we could do 45 people giving intervention during acute infection. And this is a sample size that is doable in our hands to recruit within a reasonable time. But even this, you can see that we would have 85% power to detect a difference of 55%, assuming an incredibly high success rate in the intervention arm of 75%, as well as an incredibly high rate of people accepting treatment interruption. So as we think of potential trial designs looking at giving combination therapies, it's going to be quite complex, and the sample size for each arm would be probably not that large to make it logistically possible. So some trial design considerations would be, at least in the acute context, consideration in recruitment. It's not always easy to recruit these participants. Not every site have the capability of also administrating experimental agents at time of ART initiation. So I think I look at HIV remission research at this point as exploratory studies, that we would give intervention versus a control treatment, whether placebo or just a control arm, to look for a positive signal, whether the intervention is doing anything in terms of virologic endpoint and immunologic endpoint. And I think we cannot really expect at this early stage of studies to think that a sizable portion would actually get to remission. But we're really making good progress and stepping up with bit by bit to better and better products and better well-powered study design in the future. So I think it's a very good time now with home testing becoming available, many other types of new HIV testing, that we can identify people early in infection, and that gives the opportunity to look at interventions, whether given at time of acute infection or after viral load suppression. And I'd like to acknowledge our RV254 study participants. They are so altruistic and give so much back to science, and the investigators, the funders, and all the people, the study team, as well as the people who are highlighted here who provided input and data for this presentation. So thank you so much for your attention.
It's time for one question.
Hi, gentlemen. Thank you for that. I'm Jean-Pierre from the University of Stellenbosch. How often in your acute screening protocol do you run into a scenario where you've got clients who are fourth generation negative, pooled RNA or DNA, whatever you do, positive, but on deconvolution of that pool, you don't find positive contributors? Because we've done the same for acute adult screening, and we find them rapid negative, genius negative, pooled testing positive, but upon deconvolution, none are positive. So we're not sure whether it's non-specificity, whether we need to do replicate testing per client. Your thoughts on that?
Yeah, we do pool NAT testing, I mean, to save cost. It has worked quite well in our site. We do have sometimes false positive pool when you break down and then the individual samples are negative, but that's infrequent.
Because when we apply the same concept to early infant diagnosis testing, we often do 10 replicates of normal CAP-CTM Roche, then find 2 out of 10 positive, or 3 out of 10. So I'm wondering whether the same, I suppose the RNA levels are higher in acutely infected adults than PMTCT-exposed kiddies. But
yes.
Yeah, but so it seems that you have the same problem we do.
Yes, it happens, but it's really infrequent.
Thanks.
Thank you. I think that we should finish the session. I would like to thank all the speakers and thank you all for your attention.